Welcome to The Explainer. Today, we're putting on our medical detective hats to unravel a mystery that's literally plagued humanity for millennia. We're talking about severe menstrual pain, medically known as dysmenorrhea. For way too long, this has been brushed off by some as just a normal part of life or a minor inconvenience. But when you actually look at the underlying biology, you quickly realize we're dealing with a complex, highly active physiological event. We're going to break down exactly what happens in the body, how we categorize this pain, and the escalating medical strategies used to absolutely neutralize it. Let's get into it.
To really grasp the scale of this, just look at this number. 50 to 90%. That is the staggering percentage of women affected by dysmenorrhea. So, if you've ever found yourself curled up around a heating pad, wondering why your body is suddenly at war with itself, well, this validates that you are definitely not alone. This isn't just cramps. It's a massive shared biological event, and frankly, it demands a proper scientific breakdown. Okay, let's dive into this. At its core, primary dysmenorrhea is clinically defined as painful menstruation without any underlying pelvic pathology or disease. Basically, it's the body's natural, albeit incredibly painful response to the menstrual cycle. Typically, this kicks off right around menarche, which is a girl's first period, usually between 12 and 13 years of age. From the very beginning of reproductive life, this intense chemical cascade is activated. Section 1. The reality of menstrual pain. Mapping the symptoms.
So if we're treating this pelvic pain like a crime scene, our very first step as medical detectives is to map out exactly what the victim is experiencing. We have to look way beyond just the localized pain to see the full picture of the body's systemic reaction. The clinical features here, they read like a full system alert. We aren't just talking about mild discomfort here. This is a severe cramping lower abdominal pain that can last anywhere from 8 to an agonizing 72 hours. And it doesn't just stay put. It radiates right down into the thighs and the lower back. Plus, because of the chemical signals absolutely flooding the bloodstream, patients frequently deal with nausea, vomiting, diarrhea, and just profound fatigue. Make no mistake, this is a whole body impact.
Section 2. Biology of the cramp. Investigating the culprits. So, what's actually pulling the strings here? It's time to move into the pathophysiology and investigate the biological culprits responsible for all these intense symptoms. Now, what's really interesting about this is how it perfectly visualizes the chain reaction. As the cycle ends, progesterone levels just plummet, and the sudden withdrawal of progesterone, that's the trigger. It causes the lysosomes in the endometrial lining to literally break down. Think of it like a microscopic demolition site. This breakdown releases an enzyme that frees up arachidonic acid, which then gets converted by specific cyclooxygenase enzymes into our main suspects. And those main suspects are prostaglandins, specifically PGE2 and PGF2-alpha. I want you to imagine them as an overzealous demolition crew. PGF2-alpha causes these intense, strong uterine contractions and vasoconstriction, meaning it squeezes the blood vessels super tight. This effectively cuts off the blood flow, leading to a state called ischemia. Essentially, it's starving the uterine muscle of oxygen, and the muscle just screams out in pain. Meanwhile, PGE2 is busy sensitizing your nerve endings, effectively cranking the volume dial of your pain receptors all the way up to 10. But here's the thing, prostaglandins don't act alone. They actually have accomplices in this inflammatory heist. Leukotrienes jump in to ramp up the inflammation. Vasopressin steps up to reinforce those aggressive uterine contractions. And cytokines, they join in to further sensitize your whole body to pain. It really is a highly coordinated chemical attack on your own nervous system. Section 3. Primary versus secondary pain. The fork in the road.
Now we reach a pretty pivotal moment in our investigation. So the crucial point here is understanding the difference between primary and secondary dysmenorrhea. Primary is what we've been talking about up until now. It's prostaglandin-mediated, starts within a year or so of the first period, and crucially, has no underlying disease. But secondary dysmenorrhea, that is a completely different beast. This usually rears its head 2 or more years after menarche, and it's actually driven by a distinct underlying physical pathology or structural disease in the pelvis.
To catch secondary dysmenorrhea, we really have to look for red flags. These are urgent clues that demand a much deeper medical investigation. We're talking about pain that progressively worsens over time, abnormal discharge, dyspareunia, which, by the way, is pain before, during, or after sexual intercourse, infertility, or exceptionally heavy and irregular bleeding. If these clues are present, the whole detective work shifts entirely. Because when those red flags do appear, we're usually looking at one of these specific culprits. Endometriosis is definitely the primary suspect here. It has a very high likelihood when secondary dysmenorrhea is diagnosed. But it could also be pelvic inflammatory disease, or PID. It could be adenomyosis, which is where the tissue grows deeply and thickly into the uterine wall. We're also looking at uterine myomas, like fibroids or polyps, ovarian cysts, or even pelvic congestion syndrome. Heck, it can even be caused by an intrauterine device, an IUD.
Section 4. First-line relief strategies. Neutralizing the pain. All right, once we've identified the type of pain, whether it's chemical or structural, we have to escalate our force. Let's look at how medical science actually neutralizes this pain. And this brilliantly illustrates the accessible, dual approach to treatment we have. On one side, we've got comforting, localized heat therapy, and on the other, targeted pharmacological relief using first-line NSAIDs. These are the tools most people reach for first, and honestly, there's strong science backing both of them up. But before we hit the heavy pharmaceuticals, non-pharmacological management is incredibly valid. Simply applying heat increases local blood flow, which actively fights off that painful ischemia we mapped out earlier. Regular exercise, stress reduction, and dietary changes can also do wonders to lower overall baseline inflammation. We also see some really great results from acupuncture and TENS machines, which basically use electrical impulses to scramble the pain signals, and behavioral counseling. A big one there is smoking cessation, since smoking can actually constrict blood vessels and make those cramps significantly worse.
But, when natural management just isn't enough, we bring in the NSAIDs. How do they actually work? Well, they are molecular interceptors. They specifically inhibit the COX-1 and COX-2 enzymes. By blocking these enzymes, they effectively decrease the production of prostaglandins. And no prostaglandins means fewer uterine contractions, less ischemia, and a massive reduction in pain. You're quite literally stopping that chemical demolition crew from ever showing up to the site.
Timing is absolutely everything, though. Clinical guidelines suggest starting NSAIDs like ibuprofen or mefenamic acid 1 to 2 days before menstruation even begins to preemptively block that chemical cascade. But it's crucial to be mindful here. Patients need to take things like diclofenac or naproxen with adequate food to protect the stomach, and they absolutely must be avoided during pregnancy or if a patient has renal disease. Also, a really critical warning to keep in mind, watch out for drug interactions, specifically with blood thinners like apixaban and warfarin. If traditional NSAIDs are off the table, paracetamol or targeted COX-2 inhibitors like celecoxib become the alternate routes.
Section 5. Advanced and hormonal therapies. Escalating the science.
But what happens when those first-line therapies fail and the pain just pushes right through the NSAIDs? Well, this is where we transition to the next stage of our escalation strategy, overriding the body's natural cycle through hormonal suppression. By using combined oral contraceptive pills or progestin implants like Nexplanon, doctors can essentially turn off the ovulation signal. Combined pills decrease the release of GnRH from the brain, suppressing ovulation. Meanwhile, progestin-only therapies, like implants, injections, and IUDs, cause the endometrial lining to actually atrophy or thin out. And a thinner lining means way fewer prostaglandin are released. Now let's move to and see how this builds when dealing with severe secondary dysmenorrhea, like deep infiltrating endometriosis. Here, doctors might deploy a GnR agent. This is fascinating biology. Initially, the drug stimulates the pituitary gland, but continuous administration overloads the system, causing the receptors to desensitize and downregulate, basically switching off. This induces a hypoestrogenic or menopause-like state. It aggressively thins the endometrium and halts the pain. Then, add-back therapy is administered to minimize the side effects of that state. However, we have to acknowledge that a hypoestrogenic state comes with a really heavy cost. The side effects are intense. We're talking bone loss, joint pain, vaginal dryness, and severe vasomotor symptoms like hot flashes and night sweats. So to protect the patient, doctors have to walk a clinical tightrope using that add-back therapy. They prescribe small doses of hormones like northestrone or dydrogesterone to supply just enough estrogen to stop the bone loss and the hot flashes, but keep it low enough so it doesn't wake the disease back up. It is a brilliant, highly calculated balancing act. Finally, when all pharmacological and hormonal overrides fail, surgery becomes the absolute last resort for intractable secondary dysmenorrhea. This could mean a laparoscopy to manually cut out endometrial lesions, nerve ablation to literally sever the pain pathways from the uterus to the brain, or as a final permanent resolution, a full hysterectomy. Which brings us to the end of our investigation today. We've traced the biological triggers, we've isolated those chemical accomplices, and we've mapped out an escalating arsenal of treatments, from heating pads all the way to complete hormonal shutdowns.
But all of this leaves us with one final lingering thought. As we map these incredibly complex pathways of menstrual pain, will the future of medicine finally offer a true cure? Or are we destined to just keep engineering a better Band-Aid? Thank you for exploring the science with me on this explainer today, and remember, always keep questioning what you know.